Hello, this is Jacob with the Exam 4 Essay1 essay questions. And we'll start with the first question. It says, explain how solutes and water are reabsorbed in the kidneys tubules. Be sure to include the reabsorption of sodium, glucose, water, chlorine, calcium, potassium, etc. Include in your discussion how the various solutes are reabsorbed and the concept of renal threshold and saturations. Yeah, so don't know why we started with reabsorption, but tubular reabsorption returns most of the water that's filtered and some of the solutes to the blood through these tubule cells down a nephron loop. And different pathways in different parts of this loop will allow certain types of reabsorption to occur, mainly through active transport processes. The biggest thing we think about is a sodium potassium ATP paste pump, and that is what creates this gradient, electrochemical gradient for things in solids to move through these cells, as long as it's permeable with specific channels. And that gradient can allow different types of channels, such as secondary active transports, where it maybe uses sodium to be the co-transporter for glucose to follow. And of course, typically the rule we follow for water is wherever sodium goes, water will follow. I believe about 99% of filtered water and solutes are normally reabsorbed, and the proximal tubule alone reabsorbs about 65 to 70% of sodium and chloride in water. It should, in a normal healthy person, reabsorb 100% of glucose and amino acids, but sometimes that's not the case, right? For a diabetic person, there is what we call a renal threshold, where eventually the amount of filtration, especially for glucose, isn't able to reabsorb that glucose into the blood, and thus it gets filtered through and excreted out of the body as urine. And so usually reabsorption in the later parts of the nephrons, typically the distal tubules and the collecting duct, is more variable due to hormones that regulate it, like aldosterone and ADH. Let me make sure that's part of the question. The concept of renal threshold and saturation. Yeah, so if it's pretty saturated, that typically is when we find those greater number of or greater concentration of these solutes once it hits a threshold that it doesn't get reabsorbed as well. So we'll move on to the next part of the question. Discuss the process of filtration. In your discussion, describe the filtration membrane in the renal corpuscle and the pressures involved in filtration. Okay, yeah, so that's the beginning of the filtration of this entire kidney system. So we have a blood capillary typically that goes around this part. The beginning part of the nephron is called the glomerulus, and it is located inside the Bowman's capsule. The blood will be moved into this capsule through the afferent pathway, and then it'll leave through the efferent pathway. And what happens there is that's when these solutes, these amino acids, water, glucose, tons of other proteins maybe even, will enter into the glomerulus and will possibly get filtered through. We have 3 different levels of filters right below the glomerulus. That is going to be one moment. First, we'll start off with, sorry, 1 second. If I remember correctly, or I don't. Sorry, 1 second. I gotta find this page. Okay, here we go. So we have 3 different levels. One I'm just gonna label as FE. Then there's the basement membrane and the podocyte filter. The first one, the FE, is basically going to sift through the sizes of these molecules, and whatever is small enough to fit in will pass through. I believe it's typically between 50 to 100 nanometers is the size of these pores that's in this thing. And so if it's small enough to fit in those pores, it will pass through. Then it has to try to get through the second layer, which is the basement membrane. And the basement membrane is negatively charged. And so anything that is negatively charged, any molecule, will be repelled by this basement membrane and won't filter through. And then the third layer is the podocyte filtration. It is more so of a size filter, but it does a little bit of both charge and size as well. Either way, it's even a smaller, I guess, size of a pore for these molecules to be able to pass through. So it has to be very, very tiny and not so negatively charged for any molecules to be filtered through this system. And it is controlled a little bit through pressure gradients. Inside of the glomerulus, we have a hydrostatic pressure from the arteries or the capillary bed that is typically around, I think it's 55 millimeters of mercury. And then because it has proteins flowing through them in the capillary or in the blood, we have proteins there, and albumin is going to be present again here and will contribute to BCOP, pulling the pressure or bringing the pressure into the glomerulus. I forgot to mention that the hydrostatic pressure is pressure out to the glomerulus. But BCOP is usually around, I believe it's 28 millimeters of mercury. And then right where the filters are, underneath the glomerulus, we have the third pressure, which is the capsule pressure, and it is going into the glomerulus at about 15 millimeters of mercury. And if you calculate all this, the net filtration pressure is going out of the glomerulus at about 12 millimeters of mercury. So we have a higher force trying to push all these different solutes out in a normal state. And sometimes that state can change depending on, if the capillaries of the efferent and afferent arteries will try to contract. It will either create a higher pressure or a lower pressure within the glomerulus, and changes how we even start this entire filtration process, really. Trying to make sure I got the questions right. Discuss how blood flow may be regulated. Okay, yeah, so maybe I'll go in more depth. So the afferent pathway is what starts off and enters the glomerulus. If you were to constrict that side of the capillary, you'll get very, very little blood flow in to the glomerulus, which would mean you have low pressure trying to act on the filtration rate there. Whereas if you were to constrict the efferent pathway, you're building more backup of blood in that region, and that will cause a greater pressure within the glomerulus, and maybe even cause increase in the filtration rate. And while we're talking about this topic of filtration rate, I want to bring up GFR, glomerulus filtration rate. So what is GFR? I guess it's, as it sounds, it's the rate of filtration in the glomerulus. And we want to know typically how can we estimate the GFR, because it's not typically something we can just stick a probe in and be able to measure. We use something else, a different principle called clearance. And clearance is how quickly something is cleared from the blood. But clearance doesn't always equal GFR once we've tested this experiment. And so we have to find a good way in order to calculate the filtration rate of the nephrons, or the kidneys, really. And so let's see, just trying to make sure I got something right. Okay, yeah. So the clearance is typically measured in the U of X, which I believe is urine, the amount of solids in the urine, times the rate or the volume, divided by P of X, which is pressure of a solute. And a good natural substance that we could measure the clearance of is creatine. Creatine is a byproduct left from our muscles, skeletal muscles, and it is typically 100% excreted out of the body, and we can use that then to calculate the GFR of something just by following that same equation. And normal GFR levels typically around 125 millimeters per minute is how we would measure that. But there's a lot of I guess rules or exceptions we would have to ignore in order for this to happen. One is that it has to be freely filtered naturally. There's no reabsorption of that substance. There is no secretion of the substance, no metabolism of the substance. It is not bound to anything, and that the body doesn't create it on its own, or the kidneys really creating it on its own, because then it would really not be an accurate, I guess, example of what a GFR would really be telling us. And something that we would need to also consider is something called the tubuloglomerular feedback. So just to give an example first to be able to visualize this, if we were to decrease the rate of GFR, the body will release more nitric oxide. And if we remember in the past, we thought nitric oxide was a vasoconstrictor. Well, in this case, it's actually a vasodilator for the afferent arteriole. Like I mentioned before, the one that helps bring the blood in from that side, that afferent arteriole actually dilates. It gets more, I guess, open. And this will increase the amount of blood entering the glomerulus and will ultimately increase the GFR. So the body has a really great mechanism of trying to bring the pressure or the rate of the GFR to a stable or normal level, which is typically what I mentioned, that 12 millimeters of mercury out, right, of the glomerulus. So this is the negative feedback loop for a low GFR. And for a higher than normal level of GFR, we will release adenosine, and this will vasoconstrict the afferent arteriole. So this will constrict blood from entering into the glomerulus, which will ultimately decrease the pressure and decrease the GFR for glomerulus. And this is a second type of negative feedback loop, but in the opposite way, that if in the case of a high GFR, it would try to decrease it. Okay. Let's see, we want to also explain the renin, angiotensin, and aldosterone system. So let me pull that up real quick and find that. So renin, we'll start with renin first. Renin is released from the juxtaglomerular cells in response to decreased afferent arterial pressure. So if the pressure in the afferent artery is kind of low or decreased, there is a sympathetic response to stimulate a beta-1 receptor and will decrease the amount of sodium that goes to the macula densa, right? This is just kind of anatomy. It's hard to explain where it is, but so what happens then is renin will cleave to angiotensin or angiotensinogen that comes from the liver and will convert angiotensin 1 into angiotensin 2, and this will be the main effector peptide, which will allow the what am I trying to say? We will allow more an increase in pressure. Angiotensin 2 constricts the arterioles normally, and so with a constriction of the efferent arterioles, this will help to maintain and raise even the GFR in the case of low pressure in the glomerulus, and ultimately low perfusion pressure. So we want to be able to increase that, and by constricting the efferent arteriole. So angiotensin 2 will also stimulate aldosterone to release, and we'll talk about aldosterone in a second. But this will enhance sodium and water reabsorption, and that also increases the pressure and also increases the blood volume, actually, which is what causes the higher blood pressure. So aldosterone really acts on the distal nephron, whereas I think it's the distal tubule and the collecting duct. And so, like I said, it'll try to increase the reabsorption of sodium, and in exchange, we'll try to secrete more potassium and more hydrogen atoms. But the water will follow where the sodium goes naturally. So you reabsorb it, which will increase the blood volume and will increase the pressure that you have into the overall blood circulatory system, and ultimately, I guess, into the kidneys. Let's see, go back to the question. Describe what happens at a cellular level with ADH and aldosterone. Mentioned that. Okay, in part 2 of this essay, explain how the loop of Henle is used to establish and maintain the renal medullary concentration gradient, and explain how this gradient and ADH can work together to excrete urine of different concentrations. Okay, so the loop of Henle is the combination of the descending and ascending tubules of the nephron. And as the concentration or the osmolarity of water and those solutes go down in the descending tubules, you'll actually notice that the osmolarity will increase and increase and increase. What is happening here, there's aquaporin channels on the descending tubule, and that one is only permeable to water. So water is moving out of the tubules as we go down, but all the solutes, like sodium, for example, stay. which will make it even more and more saltier, which will make it a higher concentration, higher osmolarity. The opposite is true once we're going back up the ascending tubule, and where more water is coming in and creating a lower osmolarity as we go up the ascending tubule. So in this loop of Henle, we see this change in gradients of with this sodium and water, and this will help establish a gradient all around the whole nephron system. And we want that because this is how we're going to create more energy to filter things, reabsorb things, secretes, etc. And let's see, explain how this gradient and ADH can work together to increase or to excrete urine of different concentrations. Let me find that idea first. Okay. So we have the gradient, like I mentioned, from the medullary osmotic gradient. It gives us the potential to, I guess it depends on ADH, but it gives us potential with concentrated urine. So the fluid leaving the thick ascending limb, and so this is part of the, I guess, the later tubules, and also, but the early distal tubule is a hypotonic solution once it gets there. And so because it's hypotonic, there's less water in the nephron loop, and it was reabsorbed. So in the absence of ADH, the collecting ducts are relatively impermeable to water. So the little water is almost not reabsorbed in the medulla, and the hypotonic fluid will continue through the renal pelvis and create a large amount of dilute urine to be excreted out of the body. Whereas in a situation of high ADH, aquaporin channels are inserted in the membrane, allowing water to escape, to be, I guess, reabsorbed or pass through wherever it goes. And the tubular fluid passes down through the hyperosmotic solution. It goes through the interstitium and then into the vasa recta, and the concentrated urine to the osmolarities well above plasma levels. Let's see if I missed anything. Yeah, so if it'll get excreted to be a very concentrated urine level, I guess. And so that is really the role of ADH in this factor of urine concentration. And that looks like all the questions. So thank you for listening, and we'll catch you next time.